Understood. Okay. Okay. All right. Hi, everybody. Jordan and I wanted to create a little Preceptor Teams meeting, a recording, just because we know we're doing this just a little bit last minute for our August group that is starting, that started this week. So we wanted to record so that you guys could watch at your own convenience, on your own time. I will send in the email, just the instructions when you're able to watch the recording. Send us three things that you learned. We can pay you for your time for watching all this content. Um, we wanted to create a preceptor education. We do it before each fellowship, but especially for the August group, we're making some changes. We're doing some revamps, doing a little zhuzhing. For some changes we're doing for class, some things that we're doing for skills training, so all things that we're going to be going over together during this preceptor teams. Okay, so always starting with a huge thank you. We're so thankful for you guys, all of your hard work and dedication to the new team members. We couldn't do this without you. Not only your hard work, but your warm welcomes, your patience, your kindness, is what's keeping our new team members here. So we really just wanted to, acknowledge you guys for all your hard work and the dedication that you guys are, giving to our unit. Our ultimate goal is always, growing safe and happy NICU nurses, for our NICU babies and our families. Just starting with an overview of preceptor responsibilities. So always staying connected. Really preceptors should be present for 100% of any tasks that involve like your patients, until the final tier of orientation. We do understand there are opportunities and times that are appropriate for you to let your orientee have some independence, but really in TSAM, which we'll also talk about, is that you really should be there for the bulk, the majority of patient care, and time. Debriefing with your orientee, we'll talk about that just overall on like the progress, challenges and opportunities that you're experiencing together on that shift. Like all of that time is so precious, and we don't want you guys missing out on an opportunity because the 12, 16 weeks, it seems like a lot, but it goes by quickly. And then also just immediate escalation for any, safety concerns, warning signs, anything that you're seeing, not just to the clinical mentor. We are usually, that first line of support, of course, but always knowing that if for some reason Jordan and I aren't available, our educators and even, of course, our nurse leaders, unit supervisors who are here 24/7, and then our directors, everybody is here as a support for you guys. So roles and responsibilities. The roles and responsibilities, starting with the fellowship binder. Um, I don't know if you can see the little view of me, but I'm holding up one of our fellowship binders that we give to all of our new team members that go through fellowship. So they have a little walking resource of all of the tools and things that they need to navigate orientation. We're going to talk about the TSAM objective forms later in this presentation. The expectations from you guys of what needs to be signed off. It's really, initials, dates of when they're accomplishing these objective forms or these objectives within the forms, and then signatures as well. But we'll go over that in more detail. The TSAM checklist. So this is, something that we created. It's in one of the pages after um, the TSAM objective form. Again, I'm holding it up for a little view. I know it's not like a great close up, but really taking the HealthStream checklist that we have on HealthStream. That's very long, very daunting. I got a lot of really great questions of what skill falls into which tier. So I really just took that HealthStream checklist and broke it up into the tiers of TSAM. Assignment tracker. So this is actually something that we're changing. It used to be in the fellowship binder. This was the orientee's responsibility to fill out, to go over, these are the assignments that I'm seeing at this point in orientation. I've had this number of 3 babies, this number of high acuity respiratory assignments. We're actually going to be changing this to something virtual. that our orientees are going to be able to track on Teams, so that our unit supervisors can have a very active view of the assignment tracker, what you and your orientee are seeing, what kind of assignments are you guys getting exposure to, so that day to day unit supervisors can go in, and if they do have a fill in, or maybe they're looking around the neighborhoods for an appropriate place to put you guys, they can see that in real time of, oh, this orientee's had multiple 3-baby assignments, let's get them into the SBU this shift if they're with an SBU preceptor, or let's get them something with a little higher acuity. And then, of course, the biweekly QR code. So that is just going to be the QR code that you guys scan, fill out your biweekly rounding form together of goals you'd like to achieve, where you feel like they're at in certain objectives, and any feedback moving forward and into our biweekly check-ins that we do together. So going into the biweekly check-in. So this is, for those of you that are new to precepting, this is going to be a meeting that we meet every 2 weeks with the preceptor, orientee, and mentor. We usually schedule this, obviously, for a shift that they're here with you guys. So we schedule it either at the end of a night shift. So anywhere between, sometimes we have them at, I've scheduled some for 5:30, 6:30. So we go on that 30-minute increment. But we will put those into your fellowship family email, so you know ahead of time, so that you guys can plan like the end of your shift for night shift appropriately. Obviously, patient care is going to be priority if something happens and you truly can't be there. But it is so important for you guys to be present in the biweekly check-ins, because you guys are there in real time. You have that feedback that we need to help with their progression on orientation. So we like for you to prioritize being there. But again, we do have understanding if something, happens during your shift, but just communicate that with us, especially if it's really early. Jordan and I do plan to come in. We live a little further out, so we do plan ahead of time into our commute, coming in early for those days. And then always reach out if you need to reschedule, or if there are any conflicts. We even really appreciate what Jordan and I, sometimes we just have, a little bit, we have a lot going on, and sometimes we will like overlook if we schedule somebody for a check-in, and maybe it's your first shift back together and you guys haven't had much time. We love hearing that from you guys. We may have, made that check-in intentional, and that there was no other time that we could meet with you guys. But sometimes, we really didn't have that awareness. So we love when people reach out and say, hey, I haven't been with them in a while. This is our first check-in back together. Or they mentioned they have a shadow shift during this same shift. Can we move it to another date? We're always happy to look at that. And then going over check-ins on day shift, we just call you at the beginning of your shift and see what time works best for your schedule. The biweekly QR code. So again, that's just something you'll find in the fellowship binder that your orientee will have. You'll scan the code. It no longer should say a 90-minute timeout. It used to, when you scanned the code, it said 90 minutes, and people took that as takes 90 minutes to fill out the form. That's not correct. It just will time out after 90 minutes. But I think that with the new QR code, that messaging has gone away. But it really is, so you'll scan the QR code and you guys will fill it out together. You have to fill it out on one device. So the orientee will go in, answer the questions needed, and then you will take that same device, go through and answer the questions for the preceptor. And then one of the last questions is, goals. And we really do want you to be a part of creating those goals for your orientee. That's really where, I feel like a lot of times we can, start talking about constructive feedback, which we'll talk about in some later slides. TSAM understanding. So we're going to talk about TSAM in a couple, some future slides. But really just going over that TSAM, the understanding that you should be a part, that the orientee should have their hands in every assignment. That's what TSAM is. There really is no divide and conquer. This is your patient. This is my patient. Even with the complex patients, we want them starting off, being a part of the assessment, the vital signs, the documentation, and then adding to their plate from there. Again, we'll get into some more details about this so it makes sense for those that are unfamiliar with TSAM, but just making sure you guys understand that the preceptor, you guys should have the understanding of TSAM. And if you have any questions on this, that's what Jordan and I are here for. feedback. It is your responsibility as the preceptor to escalate if you're seeing concerns, no matter how small, no matter how early. We will never, like have someone come in and give us feedback and say like, oh, like, not a big deal. We love to take that feedback, take note of it. Even when it's early on, we love to just, have an idea of what's going on with all of our orientees, our new team members, and just, for our mental awareness. Written feedback is ideal and always appreciated. I, so appreciate when people come in and tell us what's going on. We love that as well. We love that time with you guys. But written feedback really is the ideal way for us to receive the feedback, because after we receive that from you guys, we need to put it in some written form. So directly from, and sometimes, we end up talking for 30, 45 minutes. Sometimes we get into good conversation, and it ends up being pretty robust. So just hearing directly from you guys in written form is really always ideal, and also just really super helpful for Jordan and I in our process of taking in the feedback and, doing what we need with it. Support. So just always being that welcoming face, that resource for new team members, being kind and inclusive, and just creating a supportive foundation for their success. You guys are with them the majority of the time. You are that foundation of creating a community with them, and the first thing that they know in our unit. So, just wanted to add this slide of kind of going into that support, that inclusivity of, welcoming new team members to our unit. Really just thinking back, like doing a flashback for yourself of, what your first day felt like. Maybe a moment where you were like, wow, somebody just like introducing me to their friends really made me feel included. Or, a situation where my preceptor made me sit here in the neighborhood, but then didn't sit with me and I sat somewhere else. Like remembering back to personal moments that you had of like, wow, this made me feel really welcomed and included, and this made me feel not so good at the end of my shift. Um, and really just imagining like, how these things would make you feel. We have gotten feedback from new team members that have, they just they didn't feel like the Nikki was the right fit for them. They, moved on to other units, to other specialties. And not that this was everything that, they felt and why they made a change, for themselves, but they did have feedback for us on, I just really didn't feel welcomed on this unit. I just really didn't find a place for myself. And so, some of the feedback that we did get, and I just want you guys to take a moment to think about how some of these examples of new team members that went through certain things, how this would make you feel. Um, we've had people come to us and say, I, have gone into the lunchroom. My preceptor had a group of friends that were at a very large table, and she went and she sat with her friends, and I needed to go find somewhere else to eat. Um, I think, at the very least, you need to invite, I know it may be a crowded table, invite your orientee to sit with that table of your friends, introducing them to your friends, to the acquaintances that you have on the unit, or sitting with them at another table. Just those, that was like a very impactful moment for somebody where it just felt very, I had to go find somewhere else to eat, and it just felt like it was a low for that new team member. Or I had, an orientee who wasn't finished charting for the day, and the preceptor's friends were leaving for the day. She packed up, told me like finish the last few things that you have, and then left the unit and didn't wait for her orientee. So again, just like a really pivotal moment where it was like I, was left on the unit. She didn't wait for me to, finish my charting, to walk out with me. And so those were just really big moments for some team members. And, this has just been over the years, like receiving this feedback, that these were big moments for these orientees where they felt alone, they felt isolated. Our unit is already so big. So I think that doing small things like sitting with them at the nursing station, making sure that there's a place for them throughout their shift, including them in your conversations on the unit, pulling them into, hey, this is my orientee so and so, and she's just moved to Arlington, finding like common things that they can make relations with your acquaintances or your team members that are in that neighborhood. Just asking them questions about themselves. I can't tell you how many people have told me like, it was such a great day because my preceptor, asked me where I was from, or asked me about my family, asked me about my partner, my wedding that I'm planning. And that meant so much to them that you cared to ask just personal questions about them. Inviting them to lunch. I know, and I will say this, like I remember being a preceptor. I know that like sometimes like you're talking for 12 hours. It's a lot. And sometimes it's a lot for the orientee, but I think that just getting a pulse, a lot of times the orientees like, I actually appreciate when, we do take dip. She lets me go to lunch first and then I go later, or, whatever the situation is. But I think that just inviting them to lunch, having that conversation with them of, would you like lunch? To kind of have like a debrief with yourself, to like have some time, just you. But I think that people have really appreciated that just being a conversation amongst preceptor and orientee. And then again, yeah, just introducing them to other team members. Again, this has just been a huge thing of, yeah, like the neonatologists, the NMPs, respiratory therapists. Like, hi, this is my orientee. This is her second week. She's new to the unit, and this is Rasha, the RT that we're working with today. So just doing little things like that. Again, very large team. It just helps them feel included. This is a big thing to our new team members, and they want to feel included. They want to be a part of things. They want to find their place here. And I think that these little things of welcoming and including them will be huge, and definitely something that that we can do for them. So, going into what is TSAM. So, TSAM is how we organized orientation in the NICU. It's a tiered skill acquisition model. That's what it stands for. And it's based on building concepts from simple to complex. So, like I said, the orientee will have their hands in every assignment, even our babies that are a little bit more critical, but they're starting with the simplistic skills. Once they accomplish the skills that are in tier 1, they don't lose those skills. They just go into tier 2 and start adding to their plate the skills that are required from tier 2. Preceptor is responsible for everything else that is outside of the tier that they're in. So when they're just doing tier 1 with assessments, vital signs, and documentation, that's all they're handling. So you're handling everything else. You're handling the meds, the feeds, any communication with providers, holding the phone. This is all things that you'll keep onto your plate and that you will manage. Everything else will go to them. And then, as like I said earlier, as they move through the tiers, they'll gradually assume more responsibility. This is a little model that we do, we put into the fellowship binder. If you guys ever just want to quick look at what TSAM is, it's just a really nice overview of tiers 1 through 5. What is the orientee's responsibility? And then what's the preceptor's responsibility? So if you're ever, even if you're filling in and you're like, okay, I just, I don't know much about this orientee, but she's told me she's in tier 3. So I do know that tier 1 and tier 2, she's accomplished. And then, we're still working on things in tier 3. And then you can look over in your preceptor column, and have that in mind of, what your day looks like. So these are the objective forms that I was telling you guys about that are in the fellowship binder. So this will be your responsibility to fill out. We need this objective form back from them at the end of orientation. They have a health stream module that is titled TSAM, NICU TSAM NICU TSAM orientation, and we need this objective form completed and back to remove it from their health stream checklist. So it really just goes over in a very broad view the objectives that fall into the tiers 1 through 5. So starting with tier 1, you've got vital signs, assessments, cares, and documenting. So this is really where we're focusing with them. Things specific to NICU are going to be things like um, managing the vital signs, knowing your parameters, going over an assessment, what a flow of a hands-on care looks like, along with the assessment. We're very particular in the NICU, and they're not like this in all other specialties, but doing things clean to dirty, head to toe, working efficiently with our time frames and our time management, because we don't want to overstimulate our babies. So these are going to be things you're really going to work on, not only with new grads, but also new to specialty fellows, nurses they've been nurses prior to, but just not in the NICU. They're going to really need help with this. Along with documentation, so just getting used to Epic, the ins and outs of NICU documenting. We do, just for your guys' knowledge, we do set them up in their small group. So they have a small group the second week that they're here with Jordan and I, where we set up their Epic for them and we wrench in all of their flow sheets so that doesn't fall on you guys. With us having larger groups, though, there may be some orientees that you will see before the small group. They might have the small group just later that week. That's when we say, like, just give them a shadow shift, no documenting. You do the documenting, just have them observe. Once they have that small group and we get everything wrenched in and they get the documenting presentation that we also do, that will be able to click for them a little bit more. So just so you guys have an overview of what we're covering in class. Other things that, are good to go over: thermoregulation. I think starting in tier 1, I will, be honest with you guys that thermoregulation is a very complex concept for our new grads, new to specialty. Jordan made a really good point the other day that even, when we have people up on PICU that need a baby on a radiant warmer, or to go into isolate for phototherapy, we get so many calls from those team members, very capable nurses, very, very smart. But thermoregulation is just a concept that it's very different, and there's lots of ins and outs to it. So starting with thermoreg in tier 1, but just knowing that it's going to take them some time, and seeing the transitions of skin temp to air control, needing to put a baby on photo, babies that have temp instabilities and we need to pivot. So just giving grace that this will be something that they work on through their entire orientation. Hourly rounding. So this is huge for tier 1, just because we want them to know all of our ins and outs of hourly roundings on our central lines, on any IV fluid, on respiratory support, FiO2, all of our, really big safety, our safety checks right out the gate. We, in their small group, we go over safety checks with them. So they should be managing safety checks on their own from day 1 with you guys, and really just being proactive in the safety checks. I really suggest, I feel like, I've gotten feedback from some preceptors that I thought they knew what they were doing with safety checks, but when I started asking questions, or when we do our teaching round with them, which we'll go over later, we ask about safety checks and we have them talk through, and do a proactive safety check of explaining to you, not just I'm lifting the bag off of not just seeing them like, look at the ambu bag, but asking them, what are you checking with the ambu bag? So they're checking the flow to make sure it's connected correctly. They're checking the FiO2 to make sure it's above 10%. They need to verbalize those things to you, because if they're not saying them out loud, you don't know what they're checking off in their head. They need to be saying those things out loud so that you can close the loop in understanding, okay, they do know all the ins and outs of what they're checking, where it needs to be, and all of those little details. So once they've accomplished everything in tier 1, we feel like we have a good foundation there, and you guys have, what we need from you guys is for you to put your initials in the preceptor initial column, and then the date that they accomplished those objectives. So once they've accomplished things in tier 1, then you're going to go into tier 2. That's going to be medications, orders, milk preparation and feeding, and specimens. So this is where we want you to get into medications. We want them doing their 5 rights of medications and checking those with you guys. We'll talk about meds a little bit later, and what we do in orientation, but really making sure that this is where we're starting with meds for them. Order sets, especially on day shift when we're seeing orders be placed. We're seeing order changes, things like that. Milk preparation. So just going over, bottle feedings, syringe feedings, bolus, continuous. If we need to fortify, what does that look like for our ISO patients? Just going over those concepts with them along with specimens. So drawing labs. Drawing labs is an art. I'm sure you guys know if you're an experienced preceptor, it takes some time. So getting them as much experience as they can. We say, so many times in check-ins, if they're on nights, they should be drawing labs and hanging lines every single night. And if maybe it's a orientee heavy night, at least observing. They need to be in those rooms, observing the lab draws and observing the line changes. But that really should be the expectation and goal for night shifts with orientees. I think that's really all I wanted to go over for tier 2. Then tier 3 is going into a little bit more complex. So care planning, high risk procedures, communication. So this is when they're going to start holding the phone. They're going to start participating in rounds at night or reporting off or escalating to the providers, troubleshooting alarms, higher respiratory supports, PIC changes, NG-OD tube placements, things that are just, higher risk, just a little bit more complex procedures in our patient population. And also starting to demonstrate critical thinking. Critical thinking is a muscle. It's evidence-based, proven that especially new grad nurses, they're not going to be proficient in critical thinking at the end of their 16 weeks. But we do expect them, and we have the expectation that they start working that muscle, that you start asking them questions that are just going to provoke those critical thinking thoughts, that you're not just, I feel like the first couple weeks of orientation can be a lot of talking at them, giving them information, but getting away from spoon feeding them the education, getting away from you having to talk so much. Start asking, we call it Socratic teaching, but like asking them questions that helps get them to the answer, so that they're starting to put those pieces together. And then tier 4, so this is going to be admissions, discharges, transfers, and then further communication. So I like to say about this tier, so this is really the time where hopefully we're no longer concerned with, time management we're always working on, but workload management of a basic assignment. They've got their flow to hands-on care. They know what's going into each hands-on care, what meds need to be given, what tasks need to be done. This is the place where we start to promote, have your preceptor do a hands-on care. You've seen so many of those. Go see the admissions, go see the discharges, go see a nurse just educate a family going over the discharge packet. Go see the PIC placements, go see the field trip, doing all of those things and leaving the things that they're used to, like hands-on care. If they've seen a care conference before, go see something that you haven't seen. And then final tier is workload management. So this is really just going to be final tier of managing an appropriate assignment. Don't judge them off of an SBU assignment that they've had, or a really critical sick patient. Give examples of give them opportunities in stable assignments, double bubbles, room air, high flow, 3 babies, but also giving grace and knowing that 3 babies is still the ultimate test of time management. The assignments that they will have coming off of orientation, but they may still be struggling with 3 babies, but let's figure out how we get them to a place where they feel comfortable, asking for help, prioritization, organization of their day. Our biggest concern is that if people do come to us, we understand that there may be concerns of I'm just worried of what it's going to look like when they come off orientation and I'm not there. The first thing Jordan and I are going to ask you guys is, do you think that are they going to ask for help? Have they proven to you that they will ask for help, that they will escalate, that they won't just sit with themselves and say I can figure this out, or I can do all of this? That's a red flag for us. If they're not going to reach out for help, even if, they don't know what to ask for, that they are at least reaching out and looking to other resources to help with delegating and prioritization, because they're going to come off orientation, they're going to need help, they're going to need support, but it's just making sure that they're going to do that for themselves. And then with the objective form, just going back really quick, it's down here on this, below this box, but there is a place for your signature, orientee signature, and then our signature. Just make sure that you sign that when they're done with their objective forms and before the orientee turns it in. So just a brief overview of why TSAM. So really, we implemented this a couple years ago, in that it really helps with overall getting away from an incremental method or model and that divide and conquer. I will be, totally honest with you. As a preceptor, I remember doing divide and conquer. This is my baby, this is your baby. And we found, and in evidence-based practice and proven, that new hires really struggle with workflow, with prioritization and organization, and really getting less hands-on experience with that. So with TSAM, again, they have their hands in each assignment. They're practicing those skills with each patient, but then we're just adding to the plate of the tasks and the skills that they are responsible for. So this really eliminates that regression that we commonly see with 3-baby assignments. We still see the regression, but it's just it's less severe. It's less of a culture shock for them because they again have exposure to the entire assignment the entire time. So ultimate goal is better prepared new grads, and new to specialty, with the transition of coming off of orientation to being an independent practice. You will find that TSAM is wonderful because it isn't, you need to be at this place by this time. We do have loose guidelines just because we have such large fellowship groups, and it's an ICU. We like to just have a loose goal, I should say. But it's nice because what you'll commonly see if you've precepted new to specialty nurses, so nurses with experience in other areas, they will progress through the tiers a little bit quicker. So they're going to spend maybe a week in tier 1. They're going to spend a majority of their time in that tier 3 to 5, you'll see. So it's really tailored to not one person specifically. It's friendly to all experience levels. We teach them in small group that, I used to teach some of my orientees things that, in case you're hearing like, oh, well, Carly and Jordan told me this. This is where it came from. So really helping with time management and organization. So really teaching them healthy habits, all the way down to prepping for their hands-on care, going in early, grabbing all the materials. So starting off, just arriving to work on time and appropriately. Please escalate to us if you're noticing that they're rolling in while you're scrubbing in, after report, during report. This is something that, Saj does, check the time cards, but there are so many that she goes through that sometimes this just slips through the cracks. Again, you guys are seeing it in real time. So just escalate to us, even if it's the first time and you're like, they haven't done it before, but maybe it's the second time they've done it. It's just nice for us to have in our back pocket to know these things are starting, and maybe a habit that we just want to get on top of right away. Safety checks, like I was telling you guys, we do right out the gate in their first small group. We tell them about safety checks and establish the expectation that they need to be doing the safety checks right out the gate. We want them to be talking through with you though what they're doing, like I was saying earlier, being proactive, not just looking at the embu bag, lifting it off of the arm, saying that they're checking that it's above the 10% FiO2 baseline. So just making sure they're not only doing those things or they look like they're doing them, they're talking them through with you. Ensuring that they're instilling organized habits and expectations. So, clean and tidy rooms and babies, I feel like this is the first thing that gets lost just in the time management. I need to check the boxes of getting X, Y, and Z done. I need to get to my next hands on care. And when you look around the room just looks a mess. There's trash on the floor, um, maybe linen carts opened, the bedside cart is like a mess on the top. There's milk spilled everywhere. Just making sure that you like bring to light for them, and we talked to them about this as well, that they're tidying the room like a parent's about to walk through the door. Just making sure that everything looks, the way that they'd want it to, talking to them how, if like a parent came in, if this was your baby, how would you feel, especially if the baby's not put back developmentally appropriate. Setting themselves up for success, though, as well, that a baby that's put back developmentally appropriate and taking that just extra minute to make sure that the baby looks good before leaving the room is going to make a happier baby. You're not going to have to come back in there, reswaddle the baby, reposition, do all the things. And then restocking your carts for the next shift. Please instill this in them. You guys all know what it feels like to come onto shift and find a cart that's just has nothing in it. We want to be kind to the next shift, to our nurses, and set them up for success. Going in early to be on time for hands-on care. So really the ultimate goal is that feed is started by the care time, right? So especially for those babies that are getting a 2.5 hour feed, that they get that belly break that they deserve of 30 minutes. But just making sure that that's a part of their habits, their goals for themselves. So they're going to need to go in early, of course. I've had some people say that, like, my orientee is going in like 30 minutes early. Allow them to do that if that's what they need for this time. As long as like you're really telling them that really the baby should not be, stimulated, unwrapped, doing the assessment, crying, we're doing all the things for longer than like 10 minutes. If they're in there setting up, getting their organization of like all of their materials, they're warming their milk, they're not bothering the baby, those are all, okay things. But just making sure that it won't be forever that they're going in 30 minutes early. But if they just need that time in the beginning, just to allow for it, just making sure that they know the expectation of not overstimulating the baby in that care time. An organized hands-on care. So like we were talking about, head to toe, clean to dirty, all the things. Time management concerns. So a common thing that preceptors will come to us and say, hey, I am having concerns with my orientee and their time management. They're spending 45 minutes to an hour in the room. The first thing that me and Jordan are going to ask you is what's going on in the room. Like, where are you seeing, the time tick away? Like, is it the prep? Is it, that we're, going to clean, then to dirty, then we have to do hand hygiene and go back to clean? Does the flow just get interrupted? So just observe what's going on in the room. Kind of just take mental note of, just the hands-on care portion took, like, we really were, it felt like we were overstimulating the baby because the hands-on care took 20 minutes, or I don't know. So just taking note of that so that we can give the feedback, we can talk with you guys about how we make progress. Along with organized hands-on care, we do give them, a little tip and trick of organizing the materials on the bedside cart in the order of which they're going to carry them out. This is a really helpful uh, implementation for like having an organized hands-on care, and also with a talkative parent that comes in and they forget where they're at, and they can look down at their bedside cart and say, oh, my oral care is not open yet, that's where I was at in my hands-on care. And then they're not going to forget all of the other things and the materials that are after the oral care. So we do make that suggestion for them, something that you guys can use as well. It just helps with the flow, helps with the interruptions that happen, and overall we feel like we've seen great things happen with time management progress. Okay, central line changes. So we wanted to talk to you guys about central line changes, what this looks like. I did want to share with you guys, we used to, call the central line change and the medication test that we did a competency. To be more friendly, to reduce test anxiety, we are now calling them just skill stations. We're calling, it a central line change skill prep day and central line change skill station. And then for the medications, the med test that they take on orientation, we're calling it a med assessment. Just in case you hear me terming those things, we're doing a name change. Just for your awareness as well, we're also implementing things like playing soothing music during these skill days. We've implemented these these skill check forms for you guys to do with them at bedside for those that are on nights. So we're implementing things that we're hoping to take that that testing anxiety away, so that they feel comfortable and that this is truly education, checking in to make sure if they need more support, maybe going on to more nights, things like that. So for those of you that are unaware, we do a central line skill station. We do teach them in increments of, breaking the central line skill into different objectives. You can see it, some of the objectives here, which we're going to go over. Jordan and I do a introduction of education in one of the first classes that they have, just going over with them all of the objectives we want them to hit in a central line change. The goal is for them to have at least 5 central line changes with a preceptor, scoring between like a 4 to a 5, which are, a 3 to a 4 on by the last line change. We know that they're learning through this. So really the ultimate goal is that they just have a good grasp before they go into that skill day with us on a basic PICC line, TPN lipids, med line, maintaining sterility, connection to baby feels good, materials of what goes on into the line and how they connect, all of that looks good. If they do score anything less than a 4, please, 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 over here in this blue column is a little feedback comment column. Please write a comment on what feedback or support was needed that they scored less than independent. So 4 is completely independent. 3 is needing minimal guidance, 2 is needing moderate or intense guidance, and 1 is not meeting the objective at all. So if they score anything less than a 4, just let us know what's going on in that feedback. Just because we're not there in real time, we want to know, where they're needing support in whatever objective you're scoring them in. The line that they will always do is a PICC line, TPN lipids with a med line, and then they will need to change the blue clave on a Monday or Thursday night. We're just finding that a lot of sometimes they don't fall on a Monday or Thursday PM. So we want them to have that knowledge of how to change the blue clave on Monday and Thursday for our CLABSI levels. Okay, so getting into the prep for the sterile line. So that first objective that's up here. So really we're looking for collection of items so that they know the correct number of pumps they need to grab for this line that they're running. We're looking that they know the correct fluid to collect and that it's checked appropriately, that they're checking it to the MAR, that they're doing their TPN checks. Common things that we are seeing just and giving feedback on are the correct lipid tubing. So making sure that they know when to grab the small light blue lipid filter, and then when they're needing to grab the large lipid filter with the 2 ml straight tubing. So if it's SMOF, a megavan, or greater than 0.5 mLs an hour, then you're going to be grabbing the large lipid filter. And then if it's anything less than 0.5 and basic lipids, then you can grab the small filter. So just making sure that they know those things. We are making it a practice that to use clean flushes. We do not need to use sterile flushes for central line changes. They're very large flushes. They're expensive. They're not necessary. We're connecting it to a blue clave, making it a closed system. So using a clean flush for all central line changes. Cleaning the environment. So we're looking for them to know dwell time of Oxivir. We just like to ask them, I mean, it's right on the container, but just making sure that they know that there's a dwell time for everything. So Oxivir is going to be a minute, bleach is going to be 3. And we talk about that also more in our alcohol cleaning and prep of connecting to line. If sterility is broken during our skill stations and times that we're educating them, just letting them know, just to declare to us, "Hey, my blue clay fell off of my sterile field," and then we just ask them, understand things happen in real time on the unit. What would you do? And we're just looking for the correct correction of, well, I need to get a new blue clave. Um, or however they broke sterility, if they need to get all new materials, they need to get a new field, whatever that correct approach and correction response is, that's just what we're looking for. We do not dock them for that, or it's never pass fail, it's pass pause on, do we just need to like add more support here. So they just have to tell us, hey, I broke sterility and this is how I'd fix it. So then the next objective is connection of materials. So really here we're looking for them to make sure that they're using a resource. So we put the resource here that's on Teams for a PIC line, TPN, TPN lipids, and a med line, which is what they're going to be hanging in their skill station. If they need to create one for themselves, maybe if this isn't working for their brain, you're still feeling like they're having issues with the connection portions and things just aren't, like you're having to remind them over and over. Maybe they need to create one for themselves that just works for their brain. It's pretty, colorful, whatever they need to do. We talked about the clean versus sterile flush. We're only using clean flushes for central lines. Where does the two-way and the three-way go? So you can see in our resource here, we have sometimes people just mixing this up, and that closest to baby, going closest to baby, it's going to be three-way to two-way. So in that, the TPN and lipids should be connected to the two-way, and then you have your med line, your TPN and lipids, and then your extra port. This allows not only for your extra port to be closest, but also the med line. The med line also needs to be close in order to make up that 0.8 mLs and the tubing. If the med line was up here, which it would have to be if the three-way was up this way, it's the meds are not going to get to the baby. So we need to make sure that the med line is closest to baby. So that's why the three-way will be closest. So just to make sure you guys are educating that to your orientees. Knowing how to attach and prime the new blue clave for Monday and Thursday, just like I was telling you guys, I feel like we've just seen that sometimes people don't fall on Monday or Thursday night and they don't know how to connect that blue clave. They get everything connected and they will actually leave the blue clave disconnected before they start priming. So just making sure that that blue clave on a Monday, Thursday night is connected to the end of your line here, closest to baby, before they start the priming process, because that blue clave is obviously going to need to be primed through. Maintaining sterility, we talked about if they break sterility, just calling it out with appropriate corrections. And then also just making sure that all clamps are clamped prior to priming. That's one of the things we check before they start spiking bags and connecting to syringes. This is just going to help with bubbles, of course, because if you guys know, if you spike a bag that's not clamped below the spike, then you're just going to have fluid run through. You're going to have to waste a lot of fluid, remove a lot of bubbles. So just making sure that we just make it a habit for them that everything is clamped. It also gets them into a good habit that they're checking that the only thing that should be unclamped is what they're priming through. Then that should be clamped, and then they go to the next line, unclamp whatever is being primed, and they just get into a very rhythmic and healthy habit that the only thing that should be unclamped is what you're priming. Connection of line to fluid. So most commonly people use the one clean hand, which is going to be handling your central line, being the hand that holds the end of the spike or the end of where you're connecting to the syringe. And then the dirty hand handles all the bags and syringes. I'm fine with them using this. I know a lot of people have asked me, like, what is this 4x4 method? They're coming to us saying you have to use the 4x4 method. Not true. They do not need to use the 4x4 method. For those of you that haven't seen it, orientees will drop 4x4s onto their sterile fields and use the 4x4s as grabbers to grab their to use for their dirty hand, to handle the bags, to handle the syringes. The only reason that we have taught this is because sometimes we have issues with the people who have issues with the one clean hand, one dirty hand, and it just also doesn't make sense to them. Like, well, once I've touched something, I'm no longer sterile. This 4x4 method just helps with like, okay, we'll just use this to help with that dexterity of things. They do not need to use this. My suggestion of when you like offer this method to use the 4x4 is if they're having trouble with the mixing up which hands clean, which hands dirty, or if they just really can't. It's usually new to specialty nurses that are like, well, I'm no longer sterile. It's like, okay, well then let's use the 4x4. But again, just to reiterate, not necessary, not what we're teaching as end all be all, but just a method that sometimes helps. We do tell them that all fluid does need to be connected before priming starts. This really is just best practice, especially with new team members, in that we want our system to be closed. We want our bags to be spiked. We want our syringes to be connected and then the priming to start. So we have lowest risk of contamination of the line. The only vulnerable part of the line, because as you guys know, when you start to prime, you're manipulating the line, you're flicking things, you're sometimes pulling the line, around the sterile field. If everything is connected, the only part of the line we really need to just be super diligent about and thoughtful is the end of the line. So please teach your orientees and even implement into your practice. All things need to be connected first, and then you'll start your priming. The best way to teach that is to first connect your TPN, then connect your lipids, then you'll connect that flush to your extra port, and this is when you can start the priming. So you'll connect to extra port. So the reason we have you connect to extra port first is because you're connecting to that short little extra port that we don't want to just connect that flush and then leave on the sterile field. So you'll connect to extra port, prime that through. Then you'll connect the flush to the end of your med line, prime that through, and then you can go on to your lipids and your TPN. We have had some people forget to leave the flush on the med line. I know that just can be a part of practice, but leaving that flush on the med line so that we don't have to, it limits the number of times we need to access the blue clave to the med line. So just making sure that you connect the flush to the med line and then leave it there. So this is what makes the most sense in a rational, like efficient way of you really can connect TPN and lipids in whatever order, that's fine, but just making sure that everything's connected. You connect that flush last to the extra port, prime through, then remove, connect it to the med line, prime through, and then go through your other, make sure your last two things are primed. Please let me know if you guys have any questions on that. Priming fluid, so we're really just looking for no bubbles left behind with minimal fluid lost. We have had people and just in like forgetting to clamp something, or just really needing to or forgetting to flick the Lorolox. Some people have been told that you don't need to flick the Lorolox if you're going at a decent speed or if you're past the clear link filter. So some people call it like the tampon filter. Not true. Per the manufacturer, you need to flick every Lurolock because bubbles will get caught there even post filter. But we've just seen the people that don't flick the Lurolocks or get really like behind and maybe not like using their roller clamp to navigate the speed. They're wasting a lot of fluid. So just telling them, TPN lipids aren't something that we can just order. It has to be, we have to be very thoughtful and cautious of how much fluid we're using to prime through a line. So you do need to flick or turn the Lorolox, I call it the port side, so the part that you can enter into the line. So you're going to turn that down and then flick the fluid as it goes through those Lorolox to remove bubbles that get stuck there. Clamp side down. So for that clear link filter, so just making sure that clamp is always clamped as fluid is going into the clear link filter or the tampon filter, making sure that you are clamp side down and you're watching fluid go into that filter. Again, per manufacturer, that is how it's going to take in and eliminate bubbles throughout the line and for infusion. Small lipid filter. So you guys, most of you guys know, if you do look at the small blue lipid filter, it's kind of hard to see, but there is a little arrow that you'll hold up while you're priming through, again, just to help in elimination of bubbles. And then just making sure everything is primed through. I will just be honest with you guys. The only time that we truly, again, never pass, fail, pass, pause. The only there's few things that we truly take a true pause on, and one of those objectives is that if they forget to prime something through, because that is huge, right? That's going to be if they did that in real time at bedside, leaving an entire extra, the extra port, the lipids, that's a major risk for our babies of an air embolus. So just making sure that they're always doing double, triple checks, whatever. They should always know that everything is primed through. So connection of line to fluid, I will say that this is the part they're most nervous about, which rightfully so. This is when we expose the PIC. This is the most vulnerable part of the line, and there's a lot of steps, right? I mean, even this slide, there's a lot here. So just going over the objectives and some tips and tricks we teach them. So setting them up for success, even down to, you can see this image here of my baby, the baby doll that's in the isolette, even down to here's your old line that's connected to baby. This is on one side of my baby, and then you have your new line on the other side of your baby. So just making sure that there's a major differential. We've gotten feedback before that, people just in the heat of the moment connect their new line, they start disconnecting their old line, trying to get it out of the bed, detangled, and there's been times, because they don't know which line is which, that they've detangled their new line that they just hung, or the line that's connected to baby, whatever. So just making sure there's a major difference to them, that this old line's on one side, new line's on the other. I know it's kind of hard to see, but I even tell them to, the Curos caps, leave those on your new line, but for your old line, you can do the Curos caps after all is said and done. But even those green caps are just a nice visual aid for them of, okay, my green caps are my old line. If I see an end that doesn't have a Curos cap on it, that's my new line. So that's just an extra differential. For new team members. And again, just different, making sure that there's that major difference. I even, would have my orientees, my new line would go into this, the portholes, that not the hand portholes, but these little side ports up here that the EKG cables and your lines go through. Old line is in that bottom cubby, new line is in the top. Enough space with 4x4s and alcohols. So you can see this is a nice little pick. It's got a long neck on it. It looks good. We've got plenty of space here, but making sure that they have a safe place for their old pick, wherever they're changing that, cleaning the pick, it has a safe place to land. As you guys know, the bottom of the bed, which is where a majority of our picks are, that's the dirt. That's a dirty part of the bed. So the last thing that you want is, if your orientee is cleaning your pick and for some reason, loses grasp on the pick and it falls, you're not falling on a dirty linen where we change diapers, have diaper wipes, all of those things. So making sure, if you need to get a separate 4x4, or if you can use one side of your 4x4 for your old line, and then the other side for your new pick and your alcohols, just making sure that you have a safe place for this to land and a clean space for your pick to be cleaned. 4x4, 3 alcohols dropped. You'll use 1 alcohol to grab, 1 alcohol to clean the outside connection of the line. Make sure that you're educating them that the dwell time. So a lot of people know the 15-second clean, but they forget about the 15-second dry. So even that outside connection you need to make sure that you're teaching them that alcohol can't be dried if you have that alcohol over top of your, suffocating the line where you're cleaning it. So making sure they're cleaning that outside connection, but then removing the alcohol, you can keep the alcohol in your hand, but remove the alcohol pad from the outside connection, let it dry for 15 seconds. You need that dwell time to clean the bacteria that's on the outside connection of the pick. You'll use that same alcohol, remove the line, take your last alcohol, clean the exposed end of the pick for 15, let it dry for 15, and then you'll connect your new line. Okay. So just going over with them those steps, really making sure that 15-second clean is always followed by the 15-second dry, and just making sure that they feel like they're set up for success and all of that. I kind of jumped ahead, but also just, prior to the cleaning of the pick, but just making sure that, double check all is ready. I have them, have their gloves, their sterile gloves out and ready to go. That, if you have any alarms that never turn your back on the alarms, but like if you need to do a silence, if you need to put the heat curtain on, absolutely always put the heat curtain on and make sure doors are open. And then you go to clamp your pick. So just making sure that all of those things are ready before you even go in and instruct them to clamp the pick and put on their new sterile gloves. Also, just make sure that they're aware of the correct area that they're cleaning. We have a lot of people just not knowing that if they're changing the blue clave that night, they're going to be cleaning up here versus down here. So just making sure that they're cleaning at the correct connection. Do, 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 do. Next thing, just going over with them, putting all their new fluids into their pumps. And then the biggest thing that we're also trying to instill and teach is making sure that they know the rationale that the pump should be started running new fluid, and then we should always be following bag to baby and the unclamp process. The baby should be the last thing that we're unclamping. This just helps with preservation of the pick line in general, making sure we're not risking any backflow of blood down the pick. We know it doesn't usually happen that fast, but it just creates like that positive pressure if something's coming through the line. We're unclamping the line itself, unclamping that three-way to baby, and then unclamping the baby last. So the baby's always the first thing that we clamp before we, start the cleaning process, and then the last thing that we unclamp. That's a lot of things. So always, and also if you have any questions, please let us know. Hourly roundings and CLABSI bundles. So we always ask them at the end of their skill station as well, just handling our lines with care, and CLABSI is always in mind. We need to always make sure that anytime we're handling central lines, we're just looking at dressings, we're just getting, our sterile fields ready, our field prepped and cleaned with the Oxivir wipes. We're always wearing gloves when handling the line. Knowing that blue claves are changed on Monday and Thursday nights. Curo's caps need to go on all the ports. No more than one extra port for emergencies, and just knowing that they can build off that line. I think that in an ICU environment, people think, or new team members think, like as many extra ports as possible. These babies can get really sick, but them knowing that extra ports is going to increase risk of infection, and that we have more entrances than we need. Fluid bags, knowing that the fluid bag, the syringe, and the line itself needs to be labeled with the date and time the line was changed. Assessing the necessity of the line. So always just, it will be provider driven, of course, that, we're weaning fluid, that we are limiting our number of days of central lines if possible. But I think that just advocating, does that baby, are they showing signs that they can be tolerating more feed? Have we titrated fluid in a while? This is still a part of, nursing responsibilities and advocacy for our patients with providers. Always assessing volumes of bags and syringes so they don't run dry. I think that just a part of like overall hourly rounding, what are they looking at? They should be looking at the bags, the syringes, the lines itself. We've had wonderful catches with lines backing up, things not running correctly, rates being wrong, connections being cracked, dressings, making sure we're able to see dressings, clean, dry, and intact, and those kinds of things. Okay, jumping into the med assessment. We do give a med assessment on orientation because we've gotten a lot of feedback that, med calculations are an opportunity to learn. People don't know how to find neofax. People don't know how to find the right dose calculation, things like that. So things for you guys to know. We do give them this med assessment while on orientation. It's a 30 question. It's very similar to what our staff all took for the unit competency. Ours is 30 questions currently, and a passing score is 80%. It used to be 90. That was another change that we've recently made. Showing them, so part of what will help them prepare for the med assessment that we are asking you guys, We do show them NeoFax, how to get on it, how to even download the NeoFax app onto their phones. But what they really take away from things is what you guys are showing them in the day to day at the bedside. So this is really where it's going to make a pivotal change for them. So show them NeoFax, show them how to navigate it, show them how to look up the information. Um, Go over the resources on Teams. Show them the transpyloric med resource. We have questions on transpyloric feeds, what needs to be given where. The compatibility chart. Show them the King's chart in the med room, or how to use the compatibility feature in NeoFax. And even things like locations of meds. Where do you find the D10 bags? Where do we find our full saline bags? Ampicillin and Gent. Where do we find that? Really knowing that like AMP is something that we have stocked that we can pull from the unit, and then gentamicin is going to be something that they send up from pharmacy. So just telling them things like that and demonstrating those things for them will be so helpful. So what does giving meds look like for you guys, for you and your orientees? So again, just tips and tricks on how to set them up for success. So please just make sure that you're practicing your 5 rights with your orientee. So just making sure that they know right med, right route, right dose, right time, right amount, so that we're going through all these things, and that's just part of their habits, that they know that this needs to be a part of their foundation, their DNA of giving meds. They should always be checking these things. Should never be alone when giving IV medications. I know that there's going to be times where you have to step out of the room to do, an oral, like they're doing an oral med, or things like that. But IV medications are just something that sometimes they don't see as often. So just really making sure that you're present for the actual administration of IV meds. You're going over with them that 0.8, working with the med line, even slow push. Just going over those things with them. Please, please, please always have them complete their med math prior to giving a medication. We just have gotten abundance of feedback that people don't, our new team members, they don't know how to do med math, and this is huge. We are that last line of defense before our babies are getting medications. They need to know that they are giving the right medication. And it's just, it's heartbreaking to be a part of conversations where the wrong amount of med was given, especially if it was preventable. Like we've got, you guys are that second set of eyes, that's that double check that they have right there. So just really making sure that they know how to calculate that med math. If you feel like they're struggling, please let us know. This is something that we check in teaching rounds with them at bedside. But if you ever just need like a quick resource, we did put something on Teams. It's called the Med Math Admin Tip Sheet. It really just goes over medication calculations, how to do it, and something that you could help them with. But always please just let us know so that we can check in. They should know what they're giving and why they're giving it. I think that, we get into, and as a preceptor, I remember the feeling too, like caffeine, it's just so instinctual, like, okay, we give caffeine for apnea prematurity, that's why we're giving it. But they don't know that, especially, the NICU, again, so unique, so niche. Explaining to them why we're giving it, what it does for our babies, and for them to have that knowledge. And so if a parent asks, giving them those foundations now, so that when a parent does ask those questions, they can answer to them. Do they know how to find the appropriate dosing and concentrations? We've had some really great catches by bedside nurses on, medications we don't give all the time. They've double checked concentrations in NeoFax and found out that they were ordered 10 times the dose. So especially if it's something like, it's not caffeine that we give all the time, it's not hydrocort, and we're used to seeing those dosings and our usual amounts, just making sure that, and showing them where do they find that on NeoFax, so that they know the correct places to look, because again, we're that last line of defense. Feedback. So I know we touched on this a little bit, but I just want to go over just like a couple of things. So we need to know as soon as possible, even if it's small, even if it's in the beginning. Real-time feedback is truly the best, timing to give feedback. If you don't know how to give the feedback, it feels awkward, you're not sure what to say, maybe you've said it already so many times, let us know. That's what we're here for. You should not feel like you're alone in giving feedback, especially if you feel like it's just not hitting. You feel like it's just not sinking in. That's what Jordan and I are here for. We are we're so happy to help in coaching through, and we talk to you guys about this. This is what it looks like if, we're just having the conversation. But if you'd like to bring it up, just you guys because obviously our priority is always to maintain the relationship between orientee and preceptor. But we talk through those things because we're also just always happy to give the feedback. Absolutely. But we talk through what that looks like, how we can, bring up these conversations and do it proactively, do it constructively, all of the things. So um, please help us in bringing up the feedback in real time. I will say that, we love when you guys come and you tell us like, hey, this is going on. We're seeing this. But I think, like we try and set up those to have graceful conversations and check-ins. But if Jordan and I are really hitting a wall of like they're just maybe not getting the hint, they're not bringing up the things, you guys are the ones that are there in real time. And even if we're teeing something up, and I'm sure some of you guys have been in these conversations with us. Sometimes they really just don't have the awareness of like what we're trying to get at. Sometimes it's just helpful, one, to have the conversation before. It's always good to just, blame Jordan and I. Hey, we have a check-in that's coming up this morning. What goals would you like to, talk about? What would you like to work on, using the QR code for that? But then I think, again, if they're not bringing up the things that like, oh, wow, time management was a real struggle today, but they didn't see that. That's just that perfect opportunity. If you gave them the chance to be self-aware, just wasn't there, saying things like, I love those goals. Those are great opportunities. I think we should definitely bring those up to Carly and Jordan this morning. I also, feel like in this shift, there were some times where we were spending 30, 40 minutes in the room, and they were, basic hands-on care of just, starting a feed, doing an assessment, no PO feeds involved, no labs. And I'd really like to get you to a place of being at, 20, 25 minutes max. And I think that just saying, we have this wonderful opportunity where we're meeting with Carly and Jordan this morning. They are the experts in progression of orientation. Let's bring that up to them. Let's see if they have any tips and tricks for helping in making the progress that we want to see, that I want you to be at. So, blame the check-in, perfect opportunity. Let's talk about the goals, and also just giving them like an opportunity to be self-aware, because 9 times out of 10 they are aware that they could be, you know, at a different place. They could be working at a different level of a certain skill. But again, if they're not seeing that, they don't have that self-awareness. That's just when I would say, we've got this check-in with Carly and Jordan. I would really like for us to bring up this. Um, just make sure you also fill us in prior so that we're aware of that, and we can field the conversation for going that route and bringing it up gracefully, and talking through a game plan with you guys. We talked about sending us the feedback in written form, always ideal and most appreciated, but like feedback in any form, we also love to see you guys and talk in person. So really whatever works. Feedback in real time. So always finding the right time. Parents are in the room in the middle of hands-on care. They're probably not going to hear you if they're in the hustle and bustle of a hands-on care, getting all the tasks done. So it might be a time where you need to have like a debrief at the end of the hands-on care, when there's a moment, just you guys at the nursing station or outside of the room, just like saying, how do you feel like that hands-on care went? Again, giving them the opportunity to be self-aware. If they kind of miss that opportunity, they didn't see that there could be some growth, some opportunities, I think giving them a compliment, finding something that, I really feel like your charting has gotten so much better, or that conversation you had with parents, you really brought mom into the hands-on care, and that was so nice. Like I really know that made her feel really good. That made her feel included. One other thing that I feel like we could work on next hands-on care is the time management, the flow of hands-on care. A lot of times we'll give a compliment and instinctively, and I'll even do it too, give a compliment and then you say, but the orientee is only going to hear that. But they are, even if they're not acting like it, they are their own worst critic. They're so tough on themselves. they are only going to hear, that but of, oh, that was great, but, hands-on care, the flow is just all over the place. So I think that, dropping that but, and then saying just, the compliment, and then just go right into another opportunity, I think would be for us to work on time management next. But again, just talk to us. We're happy to, you shouldn't be alone in those things. So we're happy to help with presenting that. So when to escalate? Really big things here. Escalate everything, anything and everything. Again, never too small, never too early. But things I just wanted to go over of, concerns that we see, and true red flags that we want to know about immediately. So not following unit policies. So attendance issues, again, please let us know if they're arriving anytime after 7A or 7P, it's considered late. This is a new job. They need to be coming in. They shouldn't be running in and running onto the unit. They need to have that time to attend huddle, take their time getting into the day, not rushing into work. Longer than normal break times. If you feel like they're breaking and you're like, I don't know where they went, they've been gone for 45 minutes, close to an hour, this happens, please let us know, so that we can have those conversations. Not adhering to dress code, sleeping during night shifts. This is definitely a thing. I know that it seems crazy, but we do have to have conversations with them if they're falling asleep on nights. You can always say for the night shift thing, if they need to go take a walk, take a break, get a soda, get a coffee, whatever they need to do. But if it's becoming progressive, they should not be falling asleep on night shift. That's a major safety concern. Productive and proactive. Are they looking for things to do and learn? This is, I really just want to make sure that we're not getting into something that right out the gate, we have new team members that are just scrolling excessively on their phone during downtimes. There is so much to learn on the unit. Even if, in your neighborhood, it's slower, there's not a lot going on, call unit supervisor to see if there's any opportunities to go see an admission, to go on a field trip, advocate for them to, we want to see them do it on their own, but it's tough in a new environment sometimes. So just making sure that that we're not seeing excessive scrolling on the phones. Working on assignments during shifts, we really, the assignments that we give them on orientation, we do pay them for. It's additional hours outside of their shift. So they really should be doing this outside of work. And just advocating for experiences for themselves. But especially if you're we have had people advocate for experiences and they're like, oh, I've already seen that before. I don't, that's an inappropriate response. Even if they've seen a lot of admissions, it's better than just sitting there. We want them to see all the experiences multiple times. It's never too much. Lacking ability to retain basic info. So this is, just after multiple reminders of basic concepts, there is going to be times where you're going to have to, you're going to repeat yourself. But if it's basic concepts and you're really not seeing it sink in, especially if we've changed teaching strategy, we've had conversations already. They're struggling with the basic workload of an appropriate assignment that they would have coming off of orientation, or they're just unable to demonstrate like the comprehension of those skills. So like you've explained something, they say, okay, I got it, but then they're not able to actually demonstrate it. This is just a sign for us that like they may be feeling really overwhelmed. They're not absorbing what you're teaching them. It's going one in ear and one and out the other. So just making sure, like, is there something else going on here that might be just a sign to us that we maybe just need to have a different conversation of, how they're dealing with being on orientation, the acuity of the unit, all of the things. Lacking awareness on limitation. So this is huge. So if you're like having like, I don't know, they're getting babies out to do skin to skin so mom can hold and they're not telling you about it, or they're just going in giving a medication and you haven't checked it with them yet and it's a med they haven't given. Even things like giving intense prompting to ask questions. If like that, sometimes I will say that sometimes they don't know what to ask, but even if you're trying to like engage with them, you're trying to get them to start to do that critical thinking that we were talking about, and you're really having to intensely get them to, be involved and to be almost interested. This is something we want to know about. Just proven to not ask questions, blind confidence, like, so just like getting the baby out, not aware of, the safety concern with that. unaware of resources. So, if you've told them about Teams and Neofax and they're just not using those things, all things that we would like to know about and have conversations with them. Loving the NICU. So NICU is not for everybody. And we want to always condone that. Like, we want them to be, of course we want to keep them here, but we want them, we want them to be in a place where they feel like their cup's being filled. The NICU is very unique. It's very niche. I, will say commonly we'll have people come from a fast-paced, another ICU environment. And as you guys know, our unit can be fast-paced. There are days where you're running. There are days where you're really busy. There's days where your babies get really sick. It's an ICU. But day to day, the flow of the NICU can feel not as fast-paced and just not what they were expecting for an ICU. So if you're starting to see that they're just not having the love for the babies, the patient population, we are very new grad heavy. They're straight out of nursing school. They may just have like kind of a skewed version of what they thought the NICU was. So just tell us, share with us those things. We do commonly ask in check-ins, how are you liking it? Are you loving it? But I think that you guys are spending so much time with them, they usually feel more comfortable sometimes sharing with you guys what's going on and their feelings on maybe it not being the right place for them. Encourage them to talk to us about that. Just because they tell us the NICU is not the right place doesn't mean we, say, okay, well, good luck elsewhere and see you later. We really advocate for, working with our recruiters, working with HR, and finding a place that they are happy, especially if they're a solid team member all around. They're doing all of the other things. They just don't love the NICU. We want to keep them within ANOVA. We want to retain them. We just need to find the right place for them. So just make sure that, advocate and advertise for us that, we're a safe place to come and tell those feelings to, and we can advocate for them. How do they act with the baby? So this kind of goes into our other, but just like odd comments or apathy towards our patients, the families, especially families that need extra TLC. I know it can be shocking for some people, coming in, especially if they don't have babies, and some comments that they can make. But I think that overall, just, with them starting here, just wanting to make sure that they have appropriate reactions towards the things that we see every day here in the NICU. So please always escalate to us as soon as possible if you're seeing those things. Health stream checklist, very long. Those of you that are familiar with it, those of you that are new to precepting, we put in access for you guys to see the evaluate checklist hyperlink, which I will show in the next slide. This health stream checklist has all of the skills that they need to complete prior to coming off of orientation. This is the responsibility of the preceptor. The orientee cannot look at it. I would just, like, at the end of each shift or stretch of shifts, just check on this health stream checklist. Those of you that have experience with precepting and have been left with the daunting task of, maybe other preceptors just did not check this off. It's a lot of responsibility to fall on one person. So please just make sure that you're checking this periodically. So when you go to your health stream to find the checklist, you will see the options on the right side here, and it'll say evaluate checklist. If you do not see this option at all, it is because you do not have access. We give access to everybody, all of our new preceptors at the beginning of a new fellowship, but for some reason, if you don't see this, we may just need to put it in twice. So just let us know if you're not able to see this hyperlink. You'll click on that hyperlink, type in your orientee's name, and then their checklist will come up. Just some notes about precepting in the SBU. So different rules and expectations if you're precepting in the SBU. If you're precepting in the SBU and you're not an SBU nurse, maybe it's nights, you get pulled in there for help with experienced nurse coverage, and you don't feel comfortable precepting in the SBU, please just let us know. We are so happy to advocate for our unit supervisors that you don't feel comfortable, and we'll find another fill-in preceptor, SBU trained nurse for the orientees to get those SBU shifts. So we do know that, like, giving independence on the unit going into rooms, alone, doing all the things, maybe even starting cares by themselves is appropriate. In the SBU, I want you guys to have a total mind change. Different rules and expectations. These patients you should always be in the room with them. If they're going in to, set up for hands-on care, put stuff on their bedside cart, warm up milk, of course. But if they're doing hands-on care, touching the patient, and especially answering alarms, you should be with them every step of the way. If you do see, a mild regression in your orientee after being in the SBU, this is appropriate. This is a very intimidating place to be. A lot of times, we give them the overview that they are not expected to judge themselves off of an SBU day for coming off of orientation. That is not the expectations we set for them. But we want them to see the acuity. So just always letting them know that if you feel like it's a day, maybe they're more quiet, maybe hands-on care, their flows all over the place, they don't know what to grab, when to grab it. It may just because they're a little intimidated of the just the intense acuity, the care that goes on in the SBU. So this is a great day to look for experiences, see IV medications, meds that need to be given over the med line, PIC lines that need to go in. An SBU admission it can look very different than an ICU admission. Making a care plan. These babies usually have a good, care plan document and a note from providers of the start. So going over with them, this is what this baby's x-ray looked like when this happened. This is what this baby's gases looked like on admission. So going over those things, because sometimes in the SB you can have more downtime, especially if you have a one-to-one. Just expectations and rules. Please no inline suction on IVH baby bundle babies. We do have a practice doll that's intubated that last time I checked was still in the SBU, but have them practice inline suction on that baby doll. Have them practice on that baby doll before they're inline suctioning any baby, but just no IV or inline suction on our IVH babies. Please avoid heel sticks for babies that are less than 28 weeks. We've had a couple instances recently, again, just really tough feedback conversations, and it's unfortunate. They shouldn't be learning heel sticks on babies less than 28 weeks or in the SBU. If it's an appropriate, I look to you guys. If it's a more mature baby, they're at the end of of the timeline of their SBU stay, and they can practice labs on those babies. If you think it's appropriate, we look to you for that. But if they're less than 28 weeks, we really shouldn't be practicing on those babies. We've had bruising on the calf, on the heel. We just don't want that to happen for our babies. And also for the orientee, they feel so bad. They don't mean to do it. So just refrain from less than 28 weeks in lab draws. And then we already talked about, if you don't feel comfortable precepting the SBU, please let us know. So Preceptor education, just wanted to share with you a revamp on the training. So they have changed the Preceptor classes for ANOVA and System. So level 1 is the foundations of precepting. So that will be for all new preceptors. You can do that via HealthStream and register for that class via HealthStream through the catalog. It's worth 2 contact hours and can meet your advanced requirements for RN 2 and 3. Since this is new, just so that you guys know, if you guys were trained within the last year for the ANOVA Preceptor course that used to be in person, the old training will be equivalent to level 1 and 2. So you'll just jump right down to level 3, which I'll get to. Level 2 is for intermediate precepting. So that's for those that have been precepting for the last 6 months. You have to take level 1 before you take level 2. It is an in-person class, again, that you can register for on HealthStream. And this is work 2 contact hours and will be required for your RN 4 for year of 2026, so next year. So if you've already taken that in-person preceptor course in the last 5 years, you're just going to go straight to level 3. That's your advanced precepting course. This is coming soon. Again, since we have that buffer period of the last 5 years, we're looking for this to be launched in 2026. But this will be for those that have greater than a year of precepting experience. you will be able to sign up for this via HealthStream. It'll be hosted on HealthStream, and it'll be worth 1 contact hour and will be requirements for those applying for RN level, RN5 in 2026. So I just wanted to share that with you guys because those are revamps that started this year and more to come in 2026. And then that's all I have for you guys. I know this was long, but lots of information, lots of good changes. Again, we appreciate all that you do. Please come to Jordan and I for everything, small, little, as early as possible. We're here for all the things. You're not alone in this. We appreciate all that you do. And please just come to us with any questions that you have. Okay, thanks.